on the right arm is preductal. Okay. The left arm, the right leg, and the left leg are all postductal. My blood pressure and my oxygenation, my O2 sat should be the same preductal and postductal. If I have a big variation, if I have an O2 sat that's 94 here and an O2 sat on my leg that is 83, that is a big variation, okay? And that almost always means we have some kind of congenital heart defect, and it's almost always a coarctation of the aorta. Okay, so remember we talked about a little bit in class how these babies will stay in a persistent fetal circulation. So it used to be that we would send babies home and then we'd get these calls or they would show up in the ER because the baby all of a sudden was sleeping all the time and it wasn't feeding very well and it was blue. And you would see that the baby actually had a really big cardiac defect. And some of those babies died. Okay, so now we can do this screening. We do a blood pressure preductal and postductal, and before they go home, they should get an O2 saturation preductal and postductal. And there's an algorithm to follow, but if we notice that we have these big variations, then we're going to do an echo, right? A cardiac echo to see, and so let's pick that up before we send the baby home. Okay, so that's an important test, right? If they're within normal limits, both of them, or if they're close, then I can pretty much rule out a cardiac defect. Okay. Okay, and I think I did all these in the newborn assessment, so you're going to see all this different stuff here. There's just a ton, right? Because this is the first exam this baby's ever had in its whole life, right? When you get to be older, and even when even when the baby starts going in for its monthly visits, they're going to do a complete assessment every time, but eventually you start doing a focused assessment, right? And you get to a point that they don't check every single thing, but we have targeted things. So like with our 5th grade kids, we're checking for scoliosis. With our with some of our older kids, we're looking for signs of puberty. With our there's things that we check along the way. Okay. Okay, obviously I can only document what I have, right? So I either have a boy baby or a girl baby, so I'm going to document what I've got. And again, you're going to see with the Ballard that there are signs with genitalia, with skin, with cartilage that are consistent when the baby is preterm and that are consistent when the baby is term. So those things again help us define how old this baby is, and that helps us know if we're going to have problems one way or the other. Okay, it is very possible that your baby will have absolutely no lab work, but every single baby before they go home gets this newborn screen. So if it hasn't been done yet, it will be done. Okay, and the results are not going to be available right away because they actually send it to the state health department. It takes about 10 days to get the results back, and so they go back to the hospital and to the pediatrician. But these are the screening tests that screen for galactosemia, PKU disease, cystic fibrosis, sickle cell, maple syrup urine, a whole slew of thalassemia, all kinds of weird disorders that if we do nothing at all, we're going to have really big problems, congenital hypothyroidism. But if we know ahead of time, we can make a medication adaptation or a diet adaptation or something, and we can keep these kids healthy. Okay, so it's required by the state. We're not going to do a glucose unless we have a LGA or an SGA baby, right? Okay, and we're going to do a bilirubin if we have a baby that's yellow or orange. Okay, but if our baby's doing fine, we might not get it. And again, a lot of our babies get jaundice on day 3 or 4, and so that baby might be home before that happens, right? So it might be happening in the pediatrician's office. Then there's our physiology. Okay, we've already done our meds. Okay, I have a nice, normal, healthy baby. What's a potential nursing diagnosis? Is there anything wrong with them? No. Okay. Risk for fall. Okay, but what are the most likely, what are the things I'm most worried about? I'm worried about jaundice. I'm worried about hypoglycemia. I'm worried about hypothermia. ineffective thermoregulate, and I'm worried about infection, okay? So really, this is a risk for diagnosis is very appropriate. And when you look at the things that they're doing, you're gonna see that we are trying to prevent those problems, you know? So if I chose risk for infection, then my goal is no infection, right? And how am I gonna know that? I'm gonna know that because actually a baby doesn't necessarily get a high temp. Sometimes they get a low temp, or they have a hard time maintaining temperature, or they have their skin looks kind of pale or mottled or something like that. Okay. What are my interventions? Okay. Well, you're going to notice that the nursery and the NICU people are like fanatic about hand washing, obsessive about it. They do a hand scrub before you go in. They're wiping down stuff all the time. They're always washing their hands. I mean, that's part of preventing infection, right? They have other infection control measures in place in terms of washing their equipment. We give babies vaccinations, right, to prevent the hepatitis B vaccine. We give erythromycin to prevent the transfer of neonatal gonorrhea in the eyes. Okay, so think about the things that we were doing at temperature, however many times, you know, I mean, think about the things that we're doing to prevent infection or to prevent a baby that gets cold. Those are all of your interventions, okay? Just the whole hand washing spectrum is an interesting thing, from labor and delivery, postpartum to nursery and NICU. Okay, not, you know, everybody should be doing good hand washing, right, all the time, but you're just going to see that those baby people, they're just fanatic about that, and it makes sense, right? Because your baby doesn't have any immunity, and it's really easy for them to get sick, and so we got to do a much better job about not giving them something. Okay, that all looks the same. That all looks the same. Okay, so the Ballard. I'll show you a Ballard. Oh, where did it open? Okay, hold on, I have to find my Ballard. No, I opened it. Here it is. Okay, now you probably can't see it. Okay, hold on. Okay, so there's a front and a back to a Ballard. Print it and bring it with you. They do it. Okay, so those nursery nurses, they are really good. Professor Tercero. Oh, she's here. Okay, hold on. Let me tell Professor Tercero where to come. Mindy Tercero may be wandering around, lost. Oh, we have a new one? Oh, thank you. Oh, that's exciting. Thank you. Do we have to do anything else?
Yeah, we're just gonna be teaching a new class. When you come help, they'll have to watch new videos.
Okay. Oh, well, that's good.
They did a switch where, oh, you just saw it. You change the two thumb encircling with one person.
I can do what?
The two thumb encircling.
Oh, yeah. Oh, that's baby. Yeah, that's way better. Yeah. Yeah, I did it with that one. That's way better. Okay, can you guys all see the Ballard? Okay, so this is the front page. So I'm going to tell you guys, the nursery nurses, like, they don't need to look at this form. They just know what the score is and they like fly through it. But you're going to need to look at the form to know what you're doing. Okay, so it's looking at a baby. Look, this baby that's preterm over here that's getting a 0-1 is very flaccid. But my term baby should have good flexion of both upper and lower extremities. Okay, the square window is, you know, okay, so if I try and push my hand down this way with a term baby, I can actually make the palm touch over here. Okay. Arm recoil, you know, if I pump the arms a couple of times and I bring them down, a term baby has flexion, right? So it should come right back up. But a preterm baby, if I put the arms down, they're just going to stay there and not come back up very much. Okay. This scarf sign is kind of wild, you know, so the more term the baby is, the more muscle resistance there is here. And so the harder it is to get the elbow across the midline. Whereas my little preterm baby, you know, you can like do all kinds of stuff to them because they just don't have any tone there. Okay, so you put an X on what you see, and then you bring your score over here. So I got, you know, a 4 here and a 3 here and a 4 here, and then you add up your numbers for neuromuscular.
So this sheet goes with our care plan.
Yes, goes with your care plan. Yeah.
And you get to see the nurse doing this?
Yeah, hopefully you'll get to see the nurse do it because that's the best way to learn it. And sometimes you just have to ask them questions because they're pretty fast. Okay. Okay, look at their skin. So the skin is very thin preterm, and you can see all the vessels and stuff. And the older the baby gets, the thicker the skin is, the less I can see. But then also I start getting some cracking in the skin and some peeling of skin. The lanugo is the hair that's over the body, so you can see that it's a preterm baby has a lot of hair all over, and then they start kind of losing that. And so a term baby usually is just going to have some up here on the shoulders and on the back. So they're going to have bald areas or mostly bald. Okay. Our Hispanic babies tend to have more hair than non-Hispanic babies, but for the most part, when we see a baby that's covered in hair, that's a baby that's early. Okay, because that's supposed to come off. The surfaces. So look at how you have creases on your hands and on your feet. So we're going to look at the hands and the feet. So the earlier the baby is, the smoother the hands and feet are. The older the baby is, the more creases we have. So a term baby should have at least creases over the anterior 2/3 of the foot and probably over the whole sole. Okay. The chest is very flat. There's no adipose tissue there for one, right? So the nipples are flat and the breasts are flat. And as the baby gains more adipose tissue and subcutaneous flat, then we start seeing a little breast bud. And they actually measure that, okay? And we talked about the ear already, right? So they're going to do this recoil here on the ear. And so if I have a preterm baby, it's going to stay flat like this. If I have a term baby, it should have ready recoil, meaning that when I push the cartilage forward, it just bounces right back because the cartilage is already formed. And then I'm going to look at the genitalia. So let's see, Professor Turchero, she's in the lab by the gym. Okay, keep coming. Come to second floor. Follow signs. She's been here before. Why she's okay. Looks different. Okay, so the testes descend towards the end, so I should be able to palpate the testes. If I can't palpate them, then I might be able to palpate them in the inguinal canal. The scrotum should have rugae against creases on it. So the scrotum should have lots of creases on it. The smoother it is, the more preterm my baby is. If it's a little girl, as the baby girls get closer to term gestation, preterm, the clitoris is very prominent. Term, the clitoris is not prominent, and we start seeing the majora and the minora. Okay, so it's just a good way. So we add up all of our scores here, okay, and then we come up and we add up, what I get for neuromuscular, what I get for physical, what's my total score, and then I come down here and I say, okay, I got a 38, but I have something for 35 and I have something for 40. So I'm right in between here, and I'm going to follow over here and say, well, I must be 39 weeks, or maybe I got a score 40, and so I'm 40 weeks. Okay, then I go to the back of the sheet and I say my baby was 38 weeks. And so I follow my 38 weeks up and I plot out how much he weighs. And then I'll know if my baby's in this AGA normal percentile, or if he's less than 10% for weight, he's SGA, or if he's over 90%, he's LGA. So I'm going to plot out weight and head circumference and length. Okay, and that's going to tell me if I'm AGA, SGA, or LGA. Okay, questions on the Ballard? Okay, you guys are zoning out. Are you tired? Yeah, it's a lot. It's a lot in one time. Okay, so let's see. Nutrition latching. I don't know what that means.
She was replying to the problems with.
Oh, okay, to the wife. Okay. Oh, okay, problems for newborns. Yeah, so we could have ineffective breastfeeding, right? We could have a baby that's not latching on well. So we talked about some of those things. So if you are struggling, ask your faculty. Don't make it too hard. This is all very straightforward. Okay. The biggest thing, the biggest struggle that fundamental students coming right out of fundamentals has is that they're like they make it harder than it needs to be. Okay. The other thing is, when you're looking at your interventions, do not use your Ackley book. Okay. Use your textbook. Think about what you saw. I will know if you used your Ackley book, because you will tell me under ineffective regulation, thermoregulation for a newborn, you will say an oral temperature is always the best. Well, how many babies do you see getting an oral temperature? None. We do not do oral temperatures in babies, right?
Right.
Your athlete book does not, it's adult med surg stuff. So go to your textbook. There are great examples of care plans. Go to Course Point. You know, we're gonna do things differently. We're gonna look for different things. If I'm doing risk for infection with, again, remember for a baby, my signs of infection are not always a high temperature. Okay, and it might not even be a high white count. It might be that I have more neutrophils or that I have a baby that's not feeding well, that has temperature instability. If I'm doing infection for a postpartum mom or a mom in labor, okay, your white count increases in response to stress. Do you think that labor and birth is stressful? Yes. So it is not abnormal for a laboring woman or a postpartum woman to have a white count of 15,000. Does that mean she has an infection? No, it doesn't. Okay. She's also got to get rid of all that fluid that she accumulated. And so she's going to pee it out, but she's going to sweat it out too. So if she's got a white count of 15,000 and she gets up and her sheets are soaking wet, if she was a med surg patient, you would think that she had an infection. But I need more information than that, right? Because those are normal adaptations for a postpartum person, right? And so I'm going to need to look at her incision if she has one. I'm going to need to get a temperature. I may need some more information. Okay, so that's why you want to use your textbook, because it's always entertaining. Sometimes people will write something and I'm like, really? How in the world are you going to measure that? You know, we're not doing that with our, you know, they'll do something on neonatal pain or something, you know, pain for a circumcision, and they've got them using a PCA. And I'm like, I don't think so. Our babies don't know how to push a pump on a PCA, right? So don't make it harder than it needs to be.
But do you require, like, for example, the diagnosis, should we have like one risk and one actual? Or can we do
For
it
your
separately?
baby, you're not going to have an actual. You're probably not. You're probably going to have 2 risks for diagnoses. And I would say you should do at least 2 diagnoses. Sometimes there are really multiple diagnoses, but do the 2 that are the most obvious, the highest priority. Okay? Yeah, and on your newborn care plan, you will probably not have any actual diagnoses. On your labor and delivery care plan, you might get, you know, pain is going to be a diagnosis, but risk for infection, risk for bleeding, risk for injury, those are all normal things, right? On your postpartum care plan, you may have pain, or she might not be having any pain at all, and she's getting ready to go home. You know, you could have a knowledge deficit, you could have constipation or ineffective breastfeeding, but you also could have risk for hemorrhage or risk for infection, or you know, you can have risk for diagnoses. A healthy patient does not, we want to keep our healthy patients healthy, so we're looking at risk for diagnosis. Okay. And that's why you don't want to do a NICU baby. You want to do a normal healthy baby. Okay. Okay. Did I cover it all? I think I did. Let's see. Yes.
Use on the clinical skills, because according to how I understood it on the schedule, like I'm in group 101 today. So it said like, I had skills lab today, but then you sent an announcement today that we actually have it both days.
No, okay, so I don't know if I can pull that up. So we have 7 sections that are doing orientation. Oh, my battery is running low. How low am I?
You can tell from my computer.
Okay. Is there even a plug over
It'll
here?
probably take us all out.
Yeah, they probably will. Okay, hold on. I'm just gonna roll over this way so I can reach an outlet. Is that plugged in anymore?
Yeah, please.
It's right here.
Okay, don't anybody trip. I'll be in trouble with the lab. I have an incident. Okay. Okay, so everybody's here for orientation, okay, and everybody has a 1-hour skills lab. So I had to pull the people that were in Professor Gomez's group early. So they've already done their practice session, that's section 105, because they're going to the hospital tomorrow, okay? And she worked her 24-hour shift, so she came right after work. And then I think I moved some other sections around based on when their faculty could come. So hoping that you could actually meet them. So like Tercero's here somewhere, finding her way. And she's section She's actually section 107 and you guys don't start until February. There she is right there. There's Professor Tercero.